Hello everyone. Welcome to chapter 7. You're going to start part 2 of this one, and that is about a synapse. So what is a synapse? Let's take a look at this picture. You can see one neuron here is going to attach to another neuron. This attachment is called synapse. The first neuron is called presynaptic neuron because it's before synapse. The second neuron is called postsynaptic neuron. This synapse can be either electrical synapse or can be chemical synapse. What is electrical synapse? What is chemical synapse? In the case of electrical synapse, the cells are attached to each other by a gap junction. Gap junction is a protein that attaches one cell to another cell. The purpose of this gap junction is whatever happens in cell number 1, cell number 2 will know, and vice versa. Atom and molecules, they pass through the cell 1 to cell 2, or again from cell 2 to cell 1, and both cells, they are synchronized and they know exactly what's happening. This type of junction, you can see it in epithelial tissue, you can see in the smooth muscle, you can see it in the cardiac muscle that we called it intercalated disc, if you remember, and also is found in some neurons in the CNS. You may find disjunctions between glial cells as well. This protein that attaches one cell to another cell is called connexin. That's a protein. This protein is closed in the normal situation, so it's not like there's an open duct in this protein all the time. When you phosphorylate or dephosphorylate this protein, then the channel may open or close. So phosphorylation or dephosphorylation may open or close this channel or this protein. As a result, the molecule can go through and reach to the other cell. However, the most important type of synapse would be chemical synapse. What is chemical synapse? A chemical synapse is a synapse between two neurons or between a neuron and a muscle that the communication is not through direct contact between one cell and another cell. Here's the end of one neuron, and let's say this is another neuron. This neuron and the other neuron, presynaptic and postsynaptic, they are not attached to each other. As you can see, there's a cleft, there's a space between these two. So that means I have to transfer information from the first neuron to the second neuron. If I want to move my finger, how many neurons is involved here? Well, one neuron is going to come from my brain to my spinal cord, and one neuron is going to come from my spinal cord to my finger. So there are two neurons. These two neurons, they're going to talk to each other, but they are not attached to each other. That means if this is the first neuron and that's the second neuron, I have a cleft, I have a space here. How does these two neurons talk to each other then? Well, the answer is, to make sure information is going to go from first neuron to the second neuron, the first neuron should release some chemical. This is the chemical that is going to come and sit on the receptor that we have on this cell membrane and transfer the information to the second neuron. This type of synapse that the connection is through releasing chemical is called a chemical synapse. You have to understand, these two neurons are not completely separated. There is an adhesion between these two. There is a way that these two stay close to each other. And these adhesions that attach this cell to another cell are a bunch of proteins. We don't need to go through any detail of this one. I think I should only mention the name, but I want you to know that presynaptic and postsynaptic cells are held close together by something is called CAMs. CAM stands for cell adhesion molecules. These are very important in pathology. We have 4 groups of CAMs or cell adhesion molecules. Those molecules can be a family of immunoglobulin or antibody, can be a group of proteins called integrin, cadherins, or selectins. I think for our course that will be enough just to know the name of the protein, and later in pathology you're going to learn a lot about this group of proteins. So let's see how it works. In the previous discussion we said sodium is going to flow, sodium is going to move inside the axon, and finally is going to reach the end of the axon. We also mentioned last time that the end of the axon you have expansion, is called bouton. We said inside the bouton we have some vesicles that they are full of chemicals. So now let's take a look and see how it works. Sodium is going to reach to the end of this neuron, to the end of this axon, and create action potential. In other words, this area become depolarized, become positive. At the end of the axon, we have some calcium channels. These calcium channels also are voltage gated. These calcium channels are closed But when the wave of action potential reach the end of this axon and inside the axon become slightly positive, that is going to open the calcium channel. As soon as calcium channel is open, calcium is going to rush inside the cell. When the calcium comes inside the cell, we have a protein called synaptotagmin. Calcium is going to attach to synaptotagmin and create a complex. Now here's a vesicle. These vesicles, they are not randomly is inside this neuron. They are sitting and attaching to cytoskeleton. These vesicles are attached to the actin and the rest of cytoskeleton, like spectrin, by a protein called synapsin 1. Synapsin 1 is going to keep this vesicle in place. And if you want this vesicle to move toward the end of the axon and release the chemical, we have to release it from the synapsin 1. Synapsin 1 releases vesicle if it becomes phosphorylated. So phosphorylation of the synapsin 1 is going to let this vesicle go. So calcium is going to come in, is going to attach to another protein, it's called calmodulin, this one, and create a complex, it's called calcium calmodulin. Calcium calmodulin in turn is going to activate a protein, it's called protein kinase. This protein kinase is a kinase and can phosphorylate and give phosphate to the synapsin 1. As soon as phosphate is given to synapsin 1, synapsin 1 is going to lose the interest for this vesicle, and vesicle is free now, and vesicle is going to move toward the end of the neuron. You may ask why this vesicle is going to move to the end of the neuron. Well, the answer is snare. I hope you remember the protein snare that we said is used for docking and is used for exocytosis, that move this vesicle toward the docking station at the end of the vesicle. When the docking happens, then the calcium synaptotagmin fuses this vesicle to the membrane and is going to help with exocytosis. You realize that the presence of calcium here is important for two reasons. One, calcium is going to attach to synaptotagmin, and also calcium is going to attach to calmodulin to create calcium calmodulin, which in turn is going to activate protein kinase to phosphorylate synapsin, and as a result, the vesicle is free. Do not forget the role of snare complex that is going to help with docking, and finally, do not forget the role of calcium synaptotagmin that allows for fusion of the vesicle to the cell membrane. So therefore, if I block the entrance of the calcium, if I block influx of calcium, I can stop the release of the vesicle. Again, we can use this strategy to stop a seizure. So some drugs that you're going to learn in pharmacology, what they do, they inhibit the presynaptic calcium influx. They block calcium channel. As a result, you are not going to release the content of the vesicle. Now let's take a look at the detail of this neurotransmitter. When the neurotransmitter is released, they're going to sit on the receptor that is found in the postsynaptic cell. This neurotransmitter, they have to have a receptor, just like this. These are, let's say, neurotransmitter, and this is the receptor. In many cases, not all cases, the receptor itself is a gate. Let's take a look at this one. This is the receptor and also is a gate. When the chemical sits here, as you can see in this picture, the channels open. So in this case that you see, the receptor is a channel itself. By sitting this chemical, then the channels open. Sometimes sitting the ligand or chemical is going to close it. So I don't want you to think that every time a neurotransmitter or chemical sits on the receptor, the channels opens. Sometimes the ligand sits and channel closes. So unfortunately, you have to memorize case by case. Now, let's assume in this case, this is a channel and also is a receptor. And when this chemical sits here, it's going to open and allow sodium to come in. If sodium comes inside the cell, you already know what's going to happen. Inside the cell become less negative, depolarize it, and it's going to excite the cell. We call this one EPSP. It's called excitatory postsynaptic potential. In other words, by opening this channel and bringing sodium or calcium in, any positive ion that comes in is going to make inside the cell to become more positive and it's going to excite it. Therefore, we call this one excitatory postsynaptic potential. Now, let's say if this channel is chloride channel. Let's say this neurotransmitter is going to sit here and opens, and as a result, chloride is going to come in. if chloride comes, as you know, chloride is negative, and as soon as chloride is going to come inside the cell become more negative. As a result, it's going to inhibit this cell. Therefore, we call this one inhibitory postsynaptic potential, or IPSP. With the same token, if this channel is for potassium, potassium is going to leave the cell, inside the cell become negative, and as a result, we're going to create also inhibition. You have to be able to predict what is going to happen after your channel is open. If positive ion comes in, it's going to stimulate, it's called EPSP. If negative ion comes in or positive ion leaves the cell, it's called IPSP, or inhibitory postsynaptic potential. EPSP is going to move the membrane potential toward the threshold. IPSP is going to move the membrane potential away from threshold. EPSP is going to make it easier to stimulate the cell. IPSP is going to make it more difficult to stimulate the cells. In this picture, you can see as a result of entrance of sodium or calcium, your membrane potential is moving toward zero and is going to make it depolarized. And as a result of entrance of chloride or exit of potassium, your membrane potential becomes more negative and it stays away from the threshold and make it more difficult to be stimulated. We're going to discuss about EPSP and IPSP more in detail in just a few minutes. Let's go back to this picture. So far, we learned that how we're going to release this chemical, and when this chemical sits on the receptor, what may happen. Now, obviously, these chemicals are so important. Let me make sure you're clear on something that is very important. We as human beings, we are nothing but a bunch of chemicals. The chemical that we have in our brain or in our nervous system. By changing the balance of chemicals in my brain, you can change the patient's personality, mood, memory, and so many other things. For instance, you see those people that are crazy out there and they think they can talk to God, or they hear different sounds, or they see things. Why is that? Well, because there's an imbalance in their chemical in the brain, these neurotransmitters. Can we treat them? Can we help them? Absolutely yes. We give them medication, then they're going to go back to normal. People with bipolar disorder, they're maniac, they're super energetic, or people are depressed, they feel that everything is dooming and they are failures. Can we help them? Yes, because this neurotransmitter is not balanced in their brain. So if you're smart, if you're depressed, if you have obsessive compulsive disorder, if you're maniac, everything we are, our whole character depends on this neurotransmitter. So you have to understand how important this neurotransmitter is. When you give medication, you're trying to balance these neurotransmitters. So let's now focus on the neurotransmitters. The first neurotransmitter, which is the most common neurotransmitter that we have in our body, is acetylcholine. So let's discuss first about acetylcholine. Acetylcholine has two different types of receptors, nicotinic receptor and muscarinic receptor. If acetylcholine sits on nicotinic receptor versus muscarinic receptor, you may find a very different response. That is going to bring me to a very important point. Do you think neurotransmitter is important? Yes, they are very important. But what is even more important than neurotransmitter itself is the receptor for neurotransmitter. This acetylcholine may sit in one receptor and cause inhibition, but the same acetylcholine sits on the different receptor and cause excitation. How come? Because acetylcholine, all it does is stimulate that receptor. It is the receptor that is going to determine what's going to happen. If acetylcholine sits on the receptor and allows the sodium come in, the result would be stimulation. If acetylcholine sits on the receptor and allows potassium to move out, obviously the response will be inhibition. So, although neurotransmitters are super important, but even more important is the receptor itself. In medicine, in pharmaceutical, the beauty and the art is to create a medication that sits on the receptor and does what we expect to do. That's why many medications, they have side effects, because that medication is going to sit on one receptor and give the result that we want, but also the same medication may sit on another receptor and create a result that we don't want to, and that is called a side effect. So I hope this is clear. It is the receptor that determines what the final result would be. In somatic motor neuron is a neuron that goes through the skeletal system. Acetylcholine is a neurotransmitter and the receptor is nicotinic receptor. if this is a neuron and this is your muscle, at the end of this neuron, you're going to release acetylcholine. Acetylcholine is going to sit on this receptor here and it's going to stimulate this muscle. The receptor here is nicotinic receptor. This area here is called neuromuscular junction. When acetylcholine sits on nicotinic receptor in the neuromuscular junction, the result is always stimulation. Always. Do you remember autonomic nervous system? We said autonomic nervous system is a nervous system that goes to your heart, smooth muscle, and glands. And we also said autonomic nervous system has two neurons. Let's say this is your spinal cord. This is spinal cord. This is a neuron that comes out. This is second neuron is going to go, and it's going to go to your heart. We have a synapse here, and we have a synapse here. There's a synapse in the first neuron and the second neuron. There's a synapse in the second neuron and target organ, which is your heart in this case. In this ganglion here, the receptor always nicotinic receptor, and of course the neurotransmitter acetylcholine. Always. So always acetylcholine here, and always nicotinic receptor, and always stimulates. So realize we have nicotinic receptor in the ganglion of the autonomic nervous system is always nicotinic receptor. Here, however, in this end, you have muscarinic receptor, and the result may be stimulation or inhibition. For instance, in the case of heart, this neuron here is going to release acetylcholine. Acetylcholine is going to get released here and sits on the muscarinic receptor. If the target is heart, the muscarinic receptor is going to decrease the heart rate. However, if it's not heart, let's say if it's a stomach, then the muscarinic receptor is going to stimulate the stomach, it's going to excite the stomach. So as you can see, muscarinic receptor may inhibit or may stimulate different organs. In the case of heart, muscarinic receptor is going to inhibit. In the case of stomach, muscarinic receptor is going to stimulate. We're going to talk about this one in detail later, so I don't want you to get confused by now. All I want you to understand is this one. Nicotinic receptor is always stimulatory. Every time acetylcholine sits on the nicotinic receptor, always stimulates. If acetylcholine sits on the muscarinic receptor, it may stimulate or may inhibit. Don't worry about the detail of this one. All I want you to understand is muscarinic receptor may be stimulatory, may be inhibitory. So let's repeat this one more time. Acetylcholine has two receptors, nicotinic receptor and muscarinic receptor. Nicotinic receptor is always stimulatory. Muscarinic receptor can be stimulatory or inhibitory. Where do you find nicotinic receptor? It's found in the neuromuscular junction and also is found inside the ganglion of autonomic nervous system. It's always excitatory. Where do you find muscarinic receptor? You find always at the target organ, and muscarinic receptor can be inhibitory or excitatory. The word agonist is a drug or any chemical that is going to sit on the receptor and is going to mimic the action of that neurotransmitter. For instance, remember acetylcholine has a nicotinic receptor? If nicotine sits on that nicotinic receptor, can mimic the action of the neurotransmitter acetylcholine. Or muscarine can sit on the muscarinic receptor and mimic that action of acetylcholine. So the drug that we come up with, and we create the drug, and that drug is going to sit on the receptor and act like a neurotransmitter, those medications are called agonists. However, if you come up with the drug that sit on the receptor and block the receptor so acetylcholine cannot sit on it anymore, that is called antagonist. Sometimes you want to block the receptor so the neurotransmitter cannot sit there. For instance, in the case of muscarinic receptor, we have a drug is called atropine. Atropine is going to block muscarinic receptor. And in the case of nicotinic receptor, we have another drug is called Curare. Let's take a look at this diagram and see how nicotinic receptor works. Remember we said some receptor, there are channels also. In this case, the channel is closed. If 2-acetylcholine sits on this receptor is going to open, as you can see. This is a receptor and the channel. So nicotinic receptor is a receptor and channel itself. As soon as 2-acetylcholine sits here, the channel is going to open. And when the channels open, sodium and potassium, both they can move in and out. Sodium can move in, potassium can move out. What do you think would be end result of this cell? Do you think this cell will become depolarized, hyperpolarized, or is going to stay the same? In other words, do you think this cell that inside is minus 70 millivolts, do you think becomes minus 85, minus 50, or stay minus 70 and doesn't change? I hope you are thinking that always sodium is going to come in more than potassium is going to leave. Why? Because sodium is going to come in because inside the cell is negative, and also it's going to come from higher concentration to lower concentration. Potassium, however, is going to leave only because of concentration, but potassium doesn't want to leave because of the charge inside the cell. So more sodium is going to come in versus potassium is going to leave. Therefore, inside the cell from minus 70 is going to move to minus 60, minus 50, and of course is going to create excitatory postsynaptic potential. Therefore, we said nicotine receptor is always stimulatory because always more sodium comes in and stimulates this cell. Now, let's take a look at this diagram. In this diagram, let's say this is the only neuron that synapses with this cell body. Don't worry about this too. If this neuron is going to open the nicotinic receptor and sodium is going to come in, this neuron is going to bring sodium in. But let's say when it gets to the trigger zone, it's not going to change from minus 70 to minus 55. Let's say this is going to allow sodium to come in and minus 70 is going to change to minus 60, but it's not enough. Therefore, we need other neurons to come and help this one. These two also is going to bring more sodium in. As a result, these three together, they can get sodium to the trigger zone. Membrane potential at the trigger zone from minus 70 turns into minus 55. This is called summation. Now, let's take a look at this one. What if these two together stimulate this neuron, but this one is going to inhibit the neuron? So the point here is this. The end result, what is going to happen to the second neuron, to postsynaptic neuron, is the overall reaction of this cell toward the other neuron. If this neuron is inhibitory and these two are excitatory, you have to see at the end of the day, when we get to the trigger zone, does this one move from minus 70 to minus 55 or not? If it doesn't get to minus 55, no action potential is going to happen. If these two are strong enough, despite the action of this one, to bring this one to minus 55, yes, action potential will happen. So I want you to understand, in our body, it's not that one neuron attached to another neuron is going to go. Many neurons is going to synapse with one neuron. There is a complex of synapses that happens to every single neuron, and the end result is if we can move it to minus 55 or not. This picture shows exactly what we saw. Here's one neuron, here's another neuron, as you can see in this picture. The first neuron cannot move it to minus 55. The second neuron is going to come to help. If the combination of these two can bring it to the minus 55, then action potential is going to happen. However, each one by itself, they're stimulating this cell body. So each one is going to create excitatory postsynaptic potential. The point here is this. Excitatory postsynaptic potential only excites this cell. It does not guarantee that we're going to get to the minus 55. So sometimes we need to sum it. Sometimes we need to add the effect of many other neurons to make sure this postsynaptic neuron will be stimulated enough to reach to minus 55. Let's talk about muscarinic receptor. We have 5 different types of muscarinic receptor. We call M1, M2, M3, M4, and M5. We really don't need for your class to go to detail of muscarinic receptor. But I'm going to show you one of these muscarinic receptor. This is a muscarinic receptor. Acetylcholine is going to sit on the receptor. Here, the receptor is not the channel itself. The channel is here, and the receptor is here. Realize in the previous discussion, in the case of nicotinic receptor, the channel and receptor were the same thing. Here, receptor is here, but the channel is here. So the question is how this receptor is going to change the status of this channel. Well, the answer is, since they are separate from each other, we need something is called G protein. G protein is composed of 3 subunits, alpha, beta, and gamma. They're attached to each other and they're attached to a GDP. As soon as acetylcholine sits here on this receptor become activated, and as a result, this G protein is going to disown GDP, and GTP is going to attach to it. As soon as GTP attached to this alpha, alpha is going to separate from beta and gamma, and each one is going to go in different ways. Sometimes beta and gamma is going to move, sometimes alpha is going to move. In this specific example, you can see beta and gamma, they moved along the length of the membrane and they attach to this potassium channel. In this case, potassium channel is open, potassium is going to leave the cell, and as a result, inside the cell becomes more negative. From -70 is going to change to -80 or -90. In this case, acetylcholine sits on the receptor, opens potassium channel, and inhibits the cell. What you see in this picture happens in the heart. Out of those 5 subtypes of muscarinic receptor, what you find in the heart is M2 receptor. We really don't need to go to more detail than what I just told you, and I think that would be enough for this class. Attachment of beta and gamma to this channel is going to be very short and transitionary. That means quickly this GTP will break down to GDP. As a result, beta and gamma and alpha, they're going to connect to each other and everything is going to go back to normal. And potassium channel, of course, will close. If this was not heart, if this was stomach, then acetylcholine would sit here and release alpha, and alpha would go to the potassium channel and close the potassium channel. Potassium channel was open already, and alpha goes and closes it. By closing potassium channel in the stomach, potassium is going to stay inside the cell, make inside the cell more positive, as a result, stimulates the stomach. So therefore, realize in the case of the heart, beta and gamma is going to come and attach to this potassium channel and opens it. In the case of the stomach, alpha is going to move and attach to potassium channel and close it. As a result, we would say muscarinic receptor in the case of heart is inhibitory, but muscarinic receptor in the case of stomach is excitatory. This picture shows exactly what is happening. I want you to compare M2 to M1. M2 in the heart, as you can see, beta and gamma is going to attach and is going to inhibit. In the case of stomach, as you can see, we use M1. Alpha is going to attach and is going to excite, because alpha is going to close potassium channel, beta and gamma is going to open potassium channel. For the last time, muscarinic receptor can be excitatory or can be inhibitory. However, nicotine receptor is always excitatory, because always going to open the channel and sodium is going to rush inside. Therefore, nicotine receptor is always excitatory. What is going to happen to acetylcholine after acetylcholine is released? Acetylcholine is released and is going to sit on this receptor. As long as acetylcholine is going to sit on this receptor, you're going to have an effect. For instance, if this is a heart, as long as acetylcholine is going to sit on this receptor, your heart is going to be inhibited. If this one is your muscle, as long as acetylcholine is going to sit on this nicotine receptor, your muscle is going to be stimulated. That means we have to remove acetylcholine. For instance, look at my finger. Right now, I'm bending my finger. That means I contracted my muscle. Believe it or not, I released some acetylcholine. Acetylcholine sits on the muscle cell and make my muscle to contract. Now, if I want to relax it, I have to remove acetylcholine. How do I remove acetylcholine? Well, the answer is there's an enzyme, it's called acetylcholine esterase. Acetylcholine esterase is found inside the synaptic cleft. And as soon as acetylcholine is released, acetylcholine is going to attach to this acetylcholine esterase, and acetylcholine esterase is going to break it down to choline and acetate. Choline will be brought back to the presynaptic neuron. Why? Because this cell cannot make choline. This cell depends on the choline from the uptake. As soon as choline is going to come, choline and acetyl coenzyme A is going to attach to each other to create a new acetyl coenzyme A. Acetylcholine inside the vesicle is not by itself. Acetylcholine is stored with ATP and protoglycan, and as a result, every time you release it, you release ATP and protoglycan at the same time. So let's say this is a neuron and this is a muscle. What type of receptor is this one? Well, that's a nicotine receptor, because we said at the skeletal muscle we have nicotine receptor. Acetylcholine is going to get released and it's going to come and sit on this receptor. How many of this acetylcholine do we need? The answer is 2. 1, 2. What is going to happen? Sodium is going to come in, potassium is going to go out. As a result, this cell always depolarizes. We have to remove acetylcholine. The enzyme is called acetylcholine esterase. What is the result of breaking down acetylcholine? It's going to release choline and acetate. Choline is going to be brought in with sodium. It's a co-transfer. And as I said, this choline is going to be used to create a new acetylcholine. This area is called neuromuscular junction. And the area of the muscle that has this receptor, has this nicotine receptor, is called motor end plate. After acetylcholine is being broken down by acetylcholine esterase, choline is going to come back again to the presynaptic neuron. It's going to join acetylcoenzyme A. Thanks to this enzyme, it's called choline acetyltransferase, that is going to combine them to create again acetylcholine. Probably you don't need to know any detail of this table, but this table in your book shows some drugs or chemicals that is going to affect your neuromuscular junction. For instance, you all heard about botulinum toxin. This is a toxin that comes from Clostridium botulinum. This toxin is going to block the release of acetylcholine. As a result, these people go to the paralysis. They cannot move their muscle anymore because of lack of acetylcholine. Or we have another drug, it's called Curare, which is found in the nature also. What it does is going to prevent acetylcholine to sit on the nicotine receptor. We use this drug during the surgery to make sure the muscle is going to get relaxed. The list goes on and on. I don't want you to memorize all of them, but I just mentioned these two because they are pretty commonly used, especially botulinum toxin, because this is the same thing we call Botox. People, they use it to remove their wrinkles, or sometimes it's used for migraine headache. I won't ask you medication, but sometimes we use another technique. Sometimes we try to block the choline uptake. Remember, your neuron cannot create choline, and depends on the uptake of choline. We have a drug, it's called hemiclonium, that blocks this choline uptake. And finally, sometimes we need to block acetylcholine esterase. If you heard about myasthenia gravis, is a disease that patient has very bad muscle weakness. And to help them, we give them a drug like neostigmine, that this drug is going to block acetylcholine esterase. What do you think would be the result? Well, then acetylcholine is not going to break down. It's going to sit on the nicotine receptor and it's going to stimulate the receptor for a longer period of time. The last thing I want to talk about before we move on would be about Alzheimer's disease. Alzheimer's disease is the loss of neurons that release acetylcholine. Any neuron that releases acetylcholine is called cholinergic neuron. By the way, I think you should understand, we call every neuron by what they release. If a neuron releases acetylcholine, we call that neuron cholinergic neuron. So in the brain, cholinergic neurons start dying. We don't really know exactly why. We have many ideas, but for some reasons, this cholinergic neuron start dying. We know that they are very important for memory. As a result, one of the signs of this Alzheimer patient is they lose their memory. And that is going to bring us to the end of this recording. I'll get back to you with the rest of this note.